Hello, my name is Nikita Mehandru, and today I will discuss joint work with Samantha Robertson and Niloufar Salehi on machine translation deployment in medical settings. I'll be walking through the motivation, research questions, methods, results, and discussion sections of our paper. To begin, I'm going to talk about how cross-language communication happens in clinical settings and the role that machine translation plays. I'll start with a short story to illustrate the kinds of issues I'll be talking about. As part of this research, I spoke to a physician who had a patient who had just undergone a cesarean section and was struggling to put words to her pain in her native Taiwanese. The physician making rounds at this county hospital speaks English as her first language and decides to call an interpreter by phone, but the call isn't going through. Navigating such a language barrier is a regular occurrence clinicians face. With this story, I wanted to illustrate more broadly that delivering quality healthcare requires strong patient and clinician communication, which can be challenging in the presence of language barriers. Patients with limited English proficiency in the United States are more likely to face higher mortality and readmission rates. As a result, machine translation is often used by clinicians in the US as a low cost and efficient way to communicate with patients. The reliability and accuracy varies. In one study, researchers checked the accuracy of translations of common medical phrases for errors, and in particular, for Spanish and Mandarin, they found pretty high error rates. They found 8% of common medical phrases were mistranslated to Spanish and 19% to Mandarin. But that's not the whole story. Some of these mistranslations might be grammatical errors or not that important, so they also looked for mistranslations that cause clinical harm, and they found that 2% of those mistranslations caused significant clinical risk for Spanish and 8% for Mandarin. One example being, hold the kidney medicine until you talk to your doctor was mistranslated as keep the kidney medicine, the exact opposite. Our primary motivation for this work was to better understand how clinicians currently navigate language barriers, including when and why they use machine translation, if at all, what concerns they have about using such systems, and how they assess the quality of translations, whether by working with a medical interpreter or using a machine translation tool. Our three research questions can be summarized as follows. 1, how do language barriers influence verbal and written patient instructions and ultimately affect the quality of patient care? 2, what methods do clinicians employ to measure patient understanding in the presence of language barriers? And 3, how, if at all, are clinicians leveraging machine translation tools, and how do they assess the quality of such translations? We've conducted in-depth interviews with clinicians across the United States to better understand if and how they are using machine translation tools in medical settings. We ran a pilot with a few physicians to pre-test our questions and identify potentially ambiguous wording, as well as opportunities to add more questions. We found providing an example of a machine translation system, specifically Google Translate, was helpful to clinicians so they could understand the scope of the interview study and reflect on how they interacted with this tool. We recruited 20 clinicians using snowball sampling and conducted semi-structured interviews via a video conferencing tool. The interviews lasted between 20 to 45 minutes. All interviews were recorded and transcribed, and the study was approved by our institutional review board. Clinician participants were compensated for taking the time to participate in our study during the ongoing COVID-19 pandemic. Our sample includes physicians, surgeons, nurses, and midwives in the United States across the following specialties: cardiology, orthopedic surgery, nephrology, family medicine, obstetrics and gynecology, trauma surgery, and emergency medicine. Clinicians came from a range of settings and institutions, including private practice, county hospitals, community hospitals, and academic institutions. We transcribed our interview recordings and used interpretive qualitative coding. Our open-ended inductive analysis drew on elements from grounded theory methodology. Some of our sample interview questions were, can you tell me about a recent experience where you faced a language barrier with the patient, and how do you typically respond? As well as things like, can you tell me about the last time you used a machine translation tool with the patient, and how do you think the translation came out? There were two main findings of the interview study. One was around communication challenges that clinicians faced, and the second were strategies that clinicians employed to overcome these communication challenges. In terms of our first finding, We found that constraints on time and resources interfere with interlingual patient communication and adversely affect the quality of care a clinician is able to provide to a patient. These challenges were only exacerbated in low-resource medical settings. Medical interpreters are considered the gold standard for language support because they are certified translators that clinicians solicit when a language barrier with the patient arises. However, the process of calling an interpreter can be incredibly time-consuming. As one nephrologist described, you just have one or two questions and they're not too lengthy, and it's not worth calling or taking the time to call an interpreter. This trade-off of when to use a medical interpreter was expressed by a number of clinicians. In situations where medical interpreters were necessary, many clinicians expressed how an interpreter could make patient visits twice as long due to mistranslations. Clinicians described that they often cannot call an interpreter due to resource-constrained settings, the time of day, or because the patient speaks a specific dialect or less widely spoken language. We found that patient-clinician communication was also adversely affected in settings where patients had low medical literacy rates, particularly among non-English speaking populations, and in instances where there were cultural barriers between patients and clinicians. As one OBGYN described, medical literacy is so low. So patients come back all the time and they say, "Oh, I didn't understand what you had said," or "Nobody told me this," when clearly I told them that. Even when there was no clear language barrier, they really just don't understand instructions regardless of the language they're given in. When medical literacy rates were compounded by cultural differences in the context of a language divide, the quality of care a patient receives drastically decreases. Low medical literacy rates among English-speaking populations typically results in patients missing medication refills or returning to medical settings with follow-up questions. In non-English speaking patient populations, low medical literacy posed additional challenges as clinicians had trouble deciphering if the miscommunication was attributed to a mistranslation or a lack of knowledge about medical jargon in the patient's native language. We found that when faced with language barriers, clinicians preferred to rely on medical interpreters when they had access to one, had enough time, or were navigating higher stakes conversations. Clinicians recognize that Google Translate is an all-purpose technology and wasn't built to be deployed in medical settings. In high-stakes medical settings, clinicians expressed that they knew they would be accountable for mistranslation when using a machine translation system. A clinician mentioned, "If it was very complex where I needed patient's consent, I probably would have used a translator because I knew I would not be supported by Google. Nobody would back me up for Google Translate." In response to communication challenges, we found that clinicians used 4 main tactics to confirm the reliability of the communication between them and their patients, including rephrasing and simplifying medical terms, back translation, nonverbal communication, and testing patient knowledge. A recurrent theme that we found among clinicians was using simple non-medical terms when communicating with patients. Clinicians rephrased terms to improve translation accuracy. They did this with both medical interpreters who may not have knowledge of complex medical jargon and with machine translation systems, since clinicians were aware that tools like Google Translate were not trained using medical vocabulary. Some clinicians used back translation methods where they asked the interpreter to repeat back what they had translated to the patient. As one OBGYN described, "My personal practice is if I'm dealing with a high acuity situation where there is a lot of explanation and a deep amount of informed consent to be done with the patient, I actually ask the interpreter what they're telling the patient. Like, I really grill the interpreter into, how are you translating that? Can you tell it back to me? It's almost like confirm back as to what you did explain and how much of it did the patient get. So it's trying to do a closed loop communication after every 2 or 3 sentences. So summarizing as you go along rather than after 30 minutes. This was a particularly interesting finding because the use of back translation for validation has become a standard in many multilingual medical settings, but it's usually critiqued for failing to consider issues of cultural adaptation. Consistent with prior research, we found that clinicians used a variety of methods to improve communication with non-English speaking patients, including pen and paper drawings, visual aids, and gestures. Particularly when medical interpreters were not available, clinicians relied on writing to patients providing visual aids, miming, and drawing pictures. We also found that clinicians relied on social cues and teach-back methods, asking a patient to repeat information back to estimate the extent to which a patient understood what was said to them. As one orthopedic surgeon described, at the end of all my interactions, I'll ask my patient, do you understand what I'm going to be doing? Can you explain to me what we talked about? And if there's any gap there, then I either re-explain or I look for another person to help me. Clinicians in our sample face challenges providing quality care to patients with limited English proficiency, largely due to time constraints and the limited availability of skilled medical interpreters. Our participants have devised innovative strategies for coping with these challenges, including relying on back translations, nonverbal communication, and testing patient understanding. Most of our participants were excited about the potential for machine translated mediated communication with their patients, but only if it was designed appropriately and rigorously evaluated for use in clinical settings. While general purpose machine translations fall short of meeting these needs, our findings demonstrate potential for machine translation systems to be designed specifically for safe and reliable use in healthcare. We recommended 4 modifications to machine translation systems. These include the first, which is accurate translation of medical language. So prior studies of clinician attitudes towards machine translation in healthcare suggests a preference for phrase-based applications, which can limit the range of things a user can communicate, but guarantees accurate translation of those phrases. In many areas of medicine, there are common and relatively standardized topics of conversation, such as medical history and taking current symptoms. And so this lends itself to fixed phrase-based applications more easily. We suggest the potential for tools that combine phrase-based translation with neural machine translation to provide some guarantee of accuracy, but also enabling more flexible communication when necessary. Clinicians repeatedly commented on the importance of a machine translation tool having been vetted and endorsed by a governing body, such as a hospital board or medical society. Such validation typically signals that the tool was tested via a randomized control trial and that the findings were published in a peer-reviewed medical journal. Next, our approach in this research strives to reorient the goals of machine translation systems for clinical use from optimizing translation quality between 2 texts to designing for the overall quality of cross-lingual patient-clinician communication. We suggest considering a wider range of user language proficiency, which would open up new design opportunities for machine translation systems and language support more broadly. We also found that clinicians emphasized that cross-lingual communication was not only about conveying information to a patient, but also checking their understanding and offering them an opportunity to clarify as needed. We recommend that machine translation systems increasingly support this 2-way conversation. Lastly, although clinicians were aware of some of the limitations of machine translation systems, such as their unreliable performance on medical terminology, this awareness was in spite of limited transparent information from available machine translation systems. We suggest that that a machine translation system convey its limitations to its users. Our interview study with clinicians provided insight into how to design an appropriate machine translation systems for medical settings. Cross-lingual communication between clinicians and patients can greatly affect quality of care. Machine translation systems are a low-cost solution that can address challenges clinicians have when interacting with patients in the presence of language barriers. Ultimately, we recommend that machine translations, 1, account for dialect differences, 2, combine neural machine translation with professionally translated medical phrases, 3, move beyond one-to-one translations by varying language proficiency levels, 4, encourage a feedback system to check for understanding, 5, consider literacy levels of patients, and 6, set transparent safety standards and interactive suggestions for clinicians. We discuss how and when machine translation systems should be deployed in high-stake medical settings with the hope to better serve diverse patient populations. Thank you so much.